We have two eminent doctors with us to begin with this scientific session. Dr. Rahul Bhattacharya, one of the senior most endocrinologist and geriatric consultant, Director of Geriatric Service, Horizon Lifeline Multispecialty Hospital. He is also attached with Fortis and Diabetology Group of Hospital. And another person, Dr. Sanjay Sud, renowned diabetologist and endocrinologist attached to Moderator Hospital, Hooghly. And as a moderator, we have Dr. Silima Tarenia ma'am, a renowned promising endocrinologist attached to ILS Hospital and Ruby General Hospital. I would like to invite our moderator ma'am to please come forward and welcome our speakers.
Very good morning, everyone. At the very outset, I would like to thank Howrah Town Diabetes Society for arranging this wonderful academic extravaganza, like it's been for the last decade or even more. So without wasting any further time, I would like to invite our speakers for the Insulin Workshop. May I request Dr. Rahul Bhattacharya, sir, to come and start the deliberation, and Dr. Sanjay Sud, sir.
Good morning, everybody, and thanks to Dr. Silima for inviting us, and myself and Dr. Rahul will be presenting about this workshop. Basically, it's not a presentation, rather a workshop. So, to begin with, the objectives of the workshop is to understand the physiology of insulin, review the types of insulin and their profiles, then learn the initiation and titration strategies, manage hypoglycemia and adverse effects, and practical prescribing tips. So, physiology of insulin, very basic, we all know, secreted by the beta cell of pancreas, regulates the glucose uptake, glycogen synthesis, lipid metabolism, and maintains blood glucose homeostasis. Now, about the discovery of insulin, more than 100 years have passed, and a life-saving treatment for diabetes involved the collaborative work of several scientists, notably Dr. Frederick Banting, Charles Best, James Collip, and J.J.R. MacLeod. We all know about Dr. Banting and Best, we always say, but many a times the contribution of Dr. Collip and MacLeod is forgotten. So at the University of Toronto in 1921, they successfully isolated insulin from dog pancreas, which when injected lowered blood sugar levels in diabetic animals. The first human trial was conducted on Leonard Thompson, a 14-year-old type 1 diabetic, in January 1922, making a turning point in diabetes treatment. And I believe that after the discovery of corticosteroid, perhaps this is the most revolutionizing discovery of the molecule in medical science. So, the four discoverers of insulin. If we see the evolution of insulin from 1921 till now, till date, so you can see here that it was the short-acting insulin which was discovered. Then in 1950, the intermediate-acting or NPH, neutral protamine hagidron insulin, came up. Then longer-acting insulins slowly came up. Previously, it was from the oxine and bovine pancreas that the insulin was extracted. Then there was semi-lenti, ultra-lenti, and in 1982, there was a big shift when human insulin came to the market, because there was a lot of hypersensitivity reactions with the bovine and the oxine insulin, which I believe many seniors here have used in the initial days of their practice. Then came the analog phase of insulin, the semi-synthetic ones, long-acting ones, then the biosimilar ones from analog came, then ultra-long-acting ones, inhaled Afrezza and all. So many till now, the once weekly, the ultra-long acting insulin is also available. So now I ask or request Rahul to take over from here.
Good morning. So straight to the point, when to prescribe insulin. Of course, insulin was meant for type 1 patient who are insulinopenic. So type 1 is the single most important indication for insulin therapy. And previously, we always used to think that type 2 is just a matter of time. You have to wait until all other therapy fails, and then eventually all patients of type 2 will probably require insulin therapy. This is not true anymore. Many patients these days, after advent of the modern molecules, will probably never need insulin in their lifetime, but during different phases of their life, these patients, like during any critical illness or surgery, these patients probably will require insulin at least for a brief period of time. Then another indication, very important indication, is gestational diabetes mellitus, where all of you know that insulin is probably the only reliable medicine. And then if someone was already on metformin, you can still continue with metformin and the other agent, that is glibenclamide, which we rarely use in GDM patients. So you need to practically depend on insulin for GDM patients. Now, T2DM, there is a lot of hue and cry about use of insulin in T2DM these days because of two important side effects. Number one is, of course, hypoglycemia, and number two is weight gain, because all of you know that insulin is an anabolic hormone, so it tends to promote weight gain. Now let us just examine how do you start or intensify insulin. Let's look at the AACE algorithm. So the very easy approach, and probably this is favored these days, at least for the last 7 to 8 years, by all the professional organizations in the world. Previously it was like you either start with basal or with premix. Now it is more in favor of basal, basal plus, basal-bolus, because that is more physiologic. Now you can start with a basal insulin, which is a long-acting insulin. If your starting A1C is less than 8%, then you can initiate at a total daily dose of 0.1 to 0.2 units per kg. Now you may ask, why should we start insulin in the first place if my A1C is less than 8%? So this is the case which is mainly applicable for type 1, GDM, where you have to give insulin. For type 2, of course, less than 8%, you don't even consider insulin. When A1C is more than 8%, total daily dose calculation 0.2 to 0.3 units per kg. But this is only for the starting dose. Now the PK/PD will, of course, vary from patient to patient. Like the patient response will be different for different patients. So depending on the SMBG values. So the one principle, one guiding principle, fix the fasting first. That's the easiest approach. You just look at the fasting blood glucose level. If you still think it is above target, which is an individualized target for that particular patient, where you have taken into consider all the comorbid conditions, like a frail elderly or a relatively young patient who has free of comorbid conditions, where you need tighter glycemic control, you fix that first, which should be your goal FBG. And then you proceed, like if it is still above target, you just titrate every 2 to 3 days and then increase the dose of basal insulin. And then you just, in some patients, you'll probably beyond the period of initiation, which usually lasts not more than 1 month, and then you can jolly well loosen your grip, ask the patient to repeat after every maybe 7 to 14 days, and then once in a month, once everything is stable. So this period is very important, and you'll often find many this ultra long acting or long acting basal insulins like insulin glargine U300 or degludec, they have a difference in rates of hypoglycemia during this period of initiation. And later everything comes more or less equal. So fasting more than 180, you just add 20% of total daily dose. Fasting 140 to 180, you just add 10%. And if it is 110 to 139, add just 1 unit. If the patient suffers hypoglycemia, then you have to reduce. If it is less than 70%, cut down the dose by 10 to 20%. And then, so it is important to understand that in majority of patients, you don't need to write off insulin. At best, you can stop for a while, like maybe a day or two. And you need to monitor from time to time. During the time of intensification, you just look at the postprandial values. And if you find the difference between the fasting is now under control, by fasting, I mean to say all the pre-meal values. So pre-breakfast, pre-lunch, and pre-dinner. If you find pre-meal values are already under control, then and the gap between the pre-meal and the post-meal is very wide, like more than 50 to 60, then you need to think about what can be done about to check this postprandial excursion. Because all of you know PPB, postprandial hyperglycemia, is an independent risk factor for coronary artery disease. Then you have many options these days. If other options like orals fail, in that case you may consider prandial insulin. Again, you have to check the excursion. If it is say 100 or 150 or 200, what is the excursion? What is the difference between pre-meal and post-meal value? So accordingly, you introduce pre-meal insulin, which are bolus insulins, which are very, very usually the best ones are the analog ones. Ultra short-acting insulins are available. Let me clarify at this point. All insulins are same efficacy-wise. The difference is only in their time of action and, of course, the development of complications like hypoglycemia, especially nocturnal hypoglycemia. But efficacy-wise, there is practically no difference between different types of insulin. So you can graduate now to Basal Plus with 1 mealtime insulin or 2 mealtime insulin. When you require to give 3 mealtime insulin, it becomes basal bolus. So you titrate every 2 to 3 days until you reach a point where you know the patient is already at target. So as I have already told you, there are 2 approaches. One is by going the basal way, basal plus, basal bolus. The other approach is premix way or the co-formulation way, where you are trying to target both the fasting component and the postprandial component at the same time. So these combinations will have premix 30% or 25% of short-acting insulin and 70 to 75% of long-acting insulin. So in this case, it is often easier to start with because you are giving at max 2 shots. So less number of shots, patient compliance will be better, but you will probably have to make a compromise where if you are trying to increase the dose, you are just to control the postprandial excursion. In that case, it might so happen you have to increase it to a very high level to control postprandial excursion, and there will be chances of late hypoglycemia. So that's a compromise whenever we go for a premix or co-formulation, but in some patient it works very well because you have support from other oral agents. Now, This is just a comparative chart showing the different time action profile, the peaks, the duration of different insulins. I'll not bore with you that because all of you know this. So this is again the PK profile of various insulin. As expected, you can see the rapid acting insulins reach their peak very early and come back to the baseline very early, whereas the long acting or the ultra long acting, it remains in the circulation even for more than 24 hours, as with the degludec insulin or with the insulin glargine U300. Insulin glargine U100, usually its duration of action will be little less than 24 hours. So in some of your patients, you may find it insufficient if you use once daily U100 glargine, but that is very rare actually. Now, PK profile of various basal insulin, as I have already told you. NPH is the intermediate acting, Datamir, which is actually approved in GDM. These are intermediate acting, whereas glargine U, starting from glargine U100, now you have a more concentrated form, glargine U300 and degludec U100 and U200, which is not available in India. U100 is available in India. These two are the ultra long acting insulin. Now there are various advantages and disadvantages of conventional and modern or analog insulin. As I have already mentioned, efficacy wise, there is practically no difference. All the difference lies with the side effect profile. So human insulins are, the main advantage is the cost. It is really relatively inexpensive, so cost effective. And disadvantages are, since the onset of action, you need to inject it at least 30 minutes before meal, not 5 to 10 minutes. But for analog insulins, you have to ask your patient to take it 5 to 10 minutes before meal, and even if the patient forgets to take the insulin and remembers while eating, they can still take the insulin, it will still work. And higher risk of hypoglycemia will be with the older insulins, whereas analog insulin, the main advantage is lesser incidence of hypoglycemia. Now with the future insulin, these two are the once weekly insulin, one by Novo, another by Lilly. So these are once weekly insulins and these are not yet marketed, and there are several criticisms. Like some studies, some meta-analysis have found that probably this cause almost 20 to 25% more incidence of hypoglycemia because this stays longer in the circulation. So these are available as 700 units per ml. Now, this is nasal insulin. Some of you must have seen the demonstration during the last diabetes conference this year only, and this is going to be marketed very soon, maybe within the next couple of months. Now, intranasal route enables the delivery of insulin to the central nervous system in the relative absence of systemic uptake and related peripheral side effect. But make no mistake, this is primarily indicated for cognitive dysfunction, not for treatment of diabetes. For diabetes, there is a difference. You have to have inhalational insulin. So intranasal and inhalational, these are two different things. Now Afrezza, after a long hue and cry, it is going to be marketed very soon, which you can take as an inhaler. There are several problems with insulin, but overall results, the study outcome, everything is very, very encouraging. But someone having some nasal problems or intercurrent nasal problems may find it very variable. Now, Afrezza enters your bloodstream very quickly because it bypasses the normal route, so in less than a minute, and it works within about 12 minutes. It's very fast. So it just, you have the cartridges available, you can change the cartridges. So there will be a mouthpiece, you can simply, by changing the cartridge, you can reuse the device. Now, there are several changes in the delivery methods of insulin. Dr. Sud will tell you about that.
So far, now you have a lot of intelligent delivery devices also, like the Clipsulin, then the Assista, and Novopen 6. Novopen 4, it's also kept in the demonstration, the table there. So Novopen 4 we are using regularly. So now there are some smart pens which can be connected through apps, and the blood glucose that is monitored, so that is then transmitted, and these are designed to record those, and it can adjust the dose and advise you, or through the app will give you the alerts that how much insulin needs to be injected. Then there are the pumps, because once it's a talk about insulin, so we cannot do away with that. We have to mention that, though very, very few percentage of people with diabetes or in our country are put on this, but still it's nevertheless an important thing, because it gives you a lot of freedom, convenience of fewer needles, flexible lifestyle, skipping meals, exercise, eating out, erratic schedules and travels, all this is taken care of. More precise dosing, multiple basal rates, calculated bolus and correction doses, improved control, lesser hypoglycemia, because continuously the sensors are on, and it's the machines are sensing and guiding the pumps how much dose needs to be, what is the requirement, what is the blood glucose levels, and how much insulin needs to be delivered. Gastroparesis, dawn phenomena, exercise, all these things can be done away with the automated insulin delivery. Now different types of pumps are there, and very briefly these are the few, like the patch pumps, Q-Forma, then solo micro pumps or Vigo, disposable pumps. The steps towards automated insulin delivery is something like, So here the sensors, they send the information to the controller, and the CGM devices are there, which again guide how much the pump is going to initiate or deliver. The hybrid closed loop systems are there, where low glucose suspend or predictive low glucose suspend is there, basal rate adjustment, corrective basal doses, and patient has erratic blood glucose and does not bolus for all intake. If the patient is ill or on steroids, all these things are then taken care of. The Medtronic one, the newer 770G system, is very advanced, and a few patients have been put on this in our country also. And especially for type 1, it gives them the freedom, because the children, it's very difficult for the parents to always inject them and do multiple SMBGs and things like that. So for especially the younger population and type 1 diabetics, these are really handy, very costly, no doubt about that. So, the insulin pump, the basic basal dosing features are that the basal doses are programmed every 30 to 60 minutes, and increments of very micro doses like 0.025 to 0.050 units per hour, and allow the modification of basal rates in percentage for temporary basal, allow manual suspend also, integrated suspend features, and so many other intelligent controls. So now, this is about the devices and the insulin initiation and titration. So I request Rahul to please deliver.
As I have already mentioned, the best approach is to start with the basal one. So you fix the fasting first, and then titrate based on the fasting CBG values, and add prandial insulin if needed. And depending on the particular patient profile, you fix the target, postprandial targets, and increase or decrease accordingly. So there are several barriers, the patient-related barriers. Patients, they have different cultural beliefs. Sometimes they think it's their failure. Sometimes they think that, okay, because they have heard someone who has started taking insulin and died after a few months. So probably insulin is the last resort, and I'm going to die if I start taking insulin very soon. Hypoglycemia is an issue if the patient has seen someone suffering from severe hypoglycemia who was on insulin. Then needle phobia, this is prick phobia, but this is mainly because patients actually either at the time of counseling they are not properly told to discard the needles after 1 or 2 uses. Many patients will take the insulin with the same needle at least for 10-15 days, and after the first prick it gets blunted. So if you go on pricking with that same old needle, the patient will experience more and more pain. So simply by changing the needle, you can actually avoid this pain, and then it might it might ensure better adherence from the part of the patients. And then of course this non-adherence, because of very many factors are there, and then there are physician related barriers as well. Now practical prescribing take, of course, these days pens have become so convenient. Then practically we are no longer interested in using those vials, and one has to learn how to rotate the injection sites so as to avoid the other complications, especially the local ones, the skin complications of insulin therapy. One has to learn how to store the insulin properly, and one has to learn how to do SME at which times, because many of your patients will come often with the random blood glucose levels, which doesn't mean anything unless they are suffering from hypoglycemia. So it has to be in relation to a meal, either pre-meal or 2 hours, from which are standardized values. Now you have to encourage adherence and follow-ups by empowering the patients. Now some insulin pens are disposable. You can see they are kept there. Some insulin pens are not disposable, they are permanent pen, metal pens. You just need to change the cartridge like you change a refill of a pen. So those pens are there. If any one of you are interested, you can go and check the pen. Now about this rotation of injection site, only important thing is to tell your patient you have to spare 2 inches in a circular manner from the belly button or the umbilicus. Spare 2 inches in a circular manner, and you can inject anywhere outside that circle. That's all. And then if you rotate the sites, whether it is a 4 shots a day, you will probably never come back to the same site again before a week. You can have, so as you can see from the picture, you can have several such sites. So Dr. Sud will tell you about the complications which I was just referring to.
Yeah. So this lady, she was admitted with hyperglycemic crisis. She was on 70 units of insulin, premixed insulin in divided doses daily, but she landed up with a blood glucose level of 700 plus because she was not rotating the injection sites and taking for months together on these 2 sides of the umbilicus. So this lipohypertrophy, this was causing no pain to her when she was pricking because she was not changing the needles, and the insulin that was getting absorbed was negligible. So insulin storage also is very important in our tropical climate. It can be stored in room temperature once the cartridges are put up in the filled up in the pen for 2 weeks. Usually the doses, usually a cartridge, if you give in a proper dose, doesn't last longer than that, and preferably to store in 2 to 8 degrees Celsius, and always it should be checked for signs of damage like clumping, frosting or discoloration. Especially there is a tough time with the premixed ones where it's not clear, or just like the basal ones or the regular insulins, which is clear and easy to determine whether it is damaged or not. Then SMBG is one of the cornerstones of a successful insulin therapy. Patients must be empowered and guided that how they should record, and you should set individual targets, goal for their sort of comorbidities, that what their levels of fasting, what their levels of postprandial should be. You should give them a chart, something like this, where the date is there on one side, and you can have the fasting, the pre-lunch or post-lunch and pre-dinner, etc. And extra columns also where they can record or comment if they felt any problem or any dizziness or hypoglycemic symptoms and all. They can record it so that once they come back to you on the next visit, it is much easy to decipher. And the signs of symptoms of hypoglycemia, the awareness needs to be incorporated, to be percolated to the patients or the users. And hypoglycemia management should be clearly explained by the diabetes educator or the healthcare provider, that what are the signs and symptoms we all know, like sweating, tremors, confusions. It may be sudden collapse also, or loss of consciousness. Then the rule of 15 can be told, the patients can remember it easily, like 15 grams of glucose, and recheck after 15 minutes if there is a hypoglycemia. And we should educate the patients and their family members how to adjust the dose, the next meal planning once the hypoglycemia occurs. And it is very, very important to determine the renal status always before we initiate insulin, because that is one of the most important pitfall where causes hypoglycemia if we don't see the renal function. So now Rahul will be presenting this case, that is the last one, and we'll wind up.
So we start with a 52-year-old man
speaker, sir,
who is diagnosed for last 8 years, was on multiple oral medicines and has failed. Like A1C is still 9.1%, and most of the fasting values are above 200, which if you go by the RSSDI guidelines, qualifies him for initiation of insulin therapy. This person, keep that in mind, is obese. Now, given his failing oral therapy, everything was decided to initiate, and as we prefer to start with basal therapy. Our target particular patient will be between 80 to 130. So he started with basal glargine once daily at bedtime to control the fasting glucose, and then we had to add insulin lispro to control the mealtime excursions. And after 1 year, now he is proficient in carb counting and adjusting his insulin doses based on his meal patterns. A1C is now 7.2%, nearing his individualized target of less than 7%. His weight has not increased significantly, probably because of the flexibility of the regimen and increased physical activity, and he continues to monitor his blood glucose regularly. So the key points are: early initiations, don't allow the patient to remain in more than 9% for several years. If needed, do not hesitate to start insulin. If you find osmotic symptoms, do not hesitate to start insulin now. Individual approach, of course, you have to tailor the insulin regimen, and you have to fix the targets for this particular patient. Patient education and empowerment, that's the key word. You have to overcome the barriers, several which I have discussed, and the importance of titration and intensification, as I've already mentioned, because our main objective is how we can prevent the complication, and in this glycemic control is one integral part of that preventive approach. So this actually highlights a typical journey of insulin initiation in type 2 diabetes. Individual experiences and outcomes may vary, but based on various factors such as disease severity, individual response to therapy, adherence to treatment plan, and social determinants of health. Thank you very much.
প্রিমেক্স থেকে বেজাল আমি শুরু করব রাত্রি থেকে। প্রিমেক্স সকালবেলা নিয়ে ফেলেছে, কিন্তু আমি ও বললো যে প্রিমেক্সে কাজ হচ্ছে না, আমি ওকে বেজালে নিয়ে যাব। তো আপনি একটু কাইন্ডলি হিসাবটা যদি বলে দেন।
Actually, you see, if premixed, how many doses? I mean, premixed you are giving only one dose, two doses.
একটা ডোজ নিয়েছে আর নেইনি, এবার আমি ওকে রাত্রিবেলায় বেজাল শুরু করবো।
Actually, these are two different issues, sir, because if premix is not working, so you can always, if he or she is, or if not working, that means that sugar levels are not under control, it's high. That is what you want to say, right? সেটাই বলতে চাইছেন তো, যে সুগার বেশি আছে,
ও দুবার নিতে যাচ্ছে না একবার,
ও দুবার নিতে চাইছে না একবার। না, সেটা আপনাকে গাইড করতে হবে না। একবার যদি হয় তো it is difficult. There are co-formulations are available of insulin degludec and aspart, which if taken once can control, but still 24 hours control with one dose is very difficult. Now I think these will become easier once this once a week insulins are launched. So then it may become easier, but still for the postprandial peaks, you know, if the fasting can be well controlled with basal or co-formulation one dose, but if the postprandial peak will still be there if the meal is not proper, so then some short-acting oral agents like your repaglinide, that is short-acting secretagogue, or maybe AGI, or alpha-1 glucosidase inhibitor like voglibose or acarbose may need to be given to control.
গন্ডগোল পাকিয়ে গেল। আমি প্রিমিক্স থেকে বেজালে নিয়ে যাব, ওই প্লিনটা বলেন ওই যে ওয়ান সন্ধানে প্রিমিক্স থেকে বেজালে নিয়ে যাব, সেই রাস্তাটা আমাকে বলে দেন কাইন্ডলি।
রাস্তাটা এটাই, best is to explain to the patient and convince him that twice daily or thrice daily will be required, because basal bolus is the most important thing or physiological. But still, if because of the dearth of time patient যদি চাইছে যে না আমি আর পারবো না বা দুবার নেব না, অ্যাডামেন্ট যদি থাকে, ওয়ান্স ডেলি দিয়ে কন্ট্রোল করাটা মুশকিল। করা যায়, আরও ওরাল কিছু এজেন্ট অ্যাড করতে হবে। আর যদি পেশেন্ট খরচ করতে পারে তাহলে বেস্ট উইল বি টু অ্যাডভোকেট ইনসুলিন পাম্প। তো আর কিছুই প্রিক করতে হবে না, অটোমেটিক্যালি যা হওয়ার হবে।
To both our speakers for this wonderful session, and we do apologize for this time delay, but there must be multiple questions which both our speakers will be attending off the dais. Thank you so much.
Thank you, Speaker. Thank you, Chairperson. Please be there. I would like to request Dr. Somani on behalf of Howrah Diabetic Society to please come and felicitate our Speaker and Chairperson.